Sleeves for bone loss, as David said already about the cones, we'll talk about the sleeves. I personally feel the best thing that happened to the revision knee surgery is the cones and sleeves, just like pedicle screws for the spine surgery. Bone loss in TKR, revision cases more than primary cases, tibial defects are more than femoral defects, and severe varus valgus. And of course, these are the things which we deal in every day. And this is the causes of the bone loss, which we already discussed about that. Classification is already alluded to. The magnitude of bone loss observed on preoperative radiographs vastly underestimates the true magnitude of bone loss intraoperatively. This is the fundamental question every young surgeon should remember before going into theatre. David already spoke about the zone fixation. Again, a landmark paper which has given the guidelines for the revision surgery. How do you manage the defect? Minimize the defect, translation of component. This is all done even in the primary gross deformities, reconstruction of defect. So we will discuss of the reconstruction of defect. There are different methods. We will talk about the metaphyseal fixation device, that is sleeves. And metaphyseal sleeves and cones is already discussed. The only difference is sleeves are very company specific. And if I am wrong, only the DEPU has got it. I am ready to be corrected. Any other company prepared sleeves? I don't think so. Whether it is a patent or not, I have not seen sleeves there. And of course, metaphyseal sleeves and cones, there are some differences. Metaphyseal sleeve fill a metaphyseal defect and stabilize the implant. Cones fill the defect. Fixation, sequential broaching until rigid fixation in the bony canal is obtained, whereas cones, porous surface for long-time biological fixation. Mechanically linked devices, fixation is independent, which is an advantage, and sleeves improved implant stability and alignment. Cones, more flexibility in accommodating complex bone loss and varied implant positioning. Less reliance on cement for fixation, that is sleeve, and can be custom designed for specific bone defects. Of course, metaphyseal indication, AORI type 2 and 3, large central defects, uncontained lesions with deficient rim support. Availability, you all know that fully porous coated, partially fully porous coated and cemented. Femur can be done all the way, and tibia, there is nothing like fully porous coated in the sleeves. And design, it's a stepped and tapered geometry. This is a very fundamental biomechanical principle which will give its stability. Stepped sleeves compensate for substantial cavitary defects and taper in size from the proximal tibia or distal femur towards the metaphysis, and compressively load the bone for secure fixation of the metaphysis. This is the single most design principle which will help it. And construct stability, both varus and valgus is there, rotational stability is there, and axial stability is there. And advantages are basically impart rotational and axial stability, metaphyseal defect filling, ability to transfer load to the remaining cortex, and supplemental fixation with stem not necessary. And the sleeves has got a tremendous rotational freedom. We all know that. Once we put that, you can put the MBT tray the way you want on the top of that. Sleeve preparation, it's again a simple thing, IM reaping, and we are not going to waste time on that. Case 1, we got our own cases, instability, and that is sleeve. Sleeve need not sit on the tibial bone. If a gap is there, no problem. Don't get alarmed by that. And case 2, again, infection, stage 2 revision TKR. We have done the sleeve. Again, excellent result. Complications, intraoperative fracture during broaching, because especially in Indian knees, small knees, big broaching, implant breakage, implant subsidence, metallosis, difficult to remove, well-fixed sleeve. We have a complication, 38 female, pain in the right knee, history of injury to right knee, multiple surgeries on the right knee, all these done afterwards. It has come to us in 2013, Noel's hinge revision and stage 2, 5 years post-surgery, pain in the right knee, and broken implant at the stem and sleeve junction. So we got to take it out and put a new hinge on the femoral side. This is 5 years follow-up. And so there are a lot of publications. There are 43 publications with the 3008 revision total knees, and clinical scores are comparable, sleeves and cones, and sleeves lower complication rates in short and long-term follow-up. And another paper, implant survivorship 97.8%. No metaphyseal sleeve was revised for aseptic loosening. And Sanjeev Agarwal's paper again, 104 knees were evaluated, midterm follow-up, durable clinical results and radiograph fixation. And this is our paper. Both KSS and OKS showed highly significant improvement, no osteolysis, survival rate is 86%. So conclusion, it's a viable solution for managing severe bone loss in revision totally, stress distribution to the metaphyseal region and restoration of the joint line kinematics and stable fixation. And don't let this happen to your patients. End of the day, every knee surgeon should be able to know how to prepare sleeve and put it a sleeve inside. Thank you.